Thank you very much to the IPC for the invitation. I'm really honored to be here. When Dr. Bruce invited me to present a case, there was this particular patient I had in my mind, and I wanted to discuss the pain in psoriasis. Well, this is a 38-year-old male patient with psoriatic arthritis onset at age 25. 2 years later, he developed cutaneous plaque psoriasis. He's a former smoker. He had no family history of psoriasis. In 2012, he started with inflammatory low back pain. 1 year later, he started with peripheral arthritis of the knees, ankles, hands, and feet, and psoriatic plaque lesions appear on his legs. In 2015, he developed severe left hip pain. He was diagnosed with a vascular necrosis, likely related to a history of self-medicated oral steroids. In my country, patients can buy cortical steroids without any prescription. Rheumatologists started methotrexate, but this medication was very poorly tolerated by the patient. In 2020, infliximab was started, and this resulted in joint improvement, but only with partial skin clearance. This was the patient. He was on infliximab for 3 years with irregular administration. He developed later a secondary failure. In March of 2023, he started ustekinumab 45 milligrams with only partial skin response, achieving just a PASI 75, probably because he was overweight, but we could not increase the ustekinumab dose. 1 year later, he came back to my office. He was on prednisone 20 milligrams a day for over 6 months in order to relieve the pain he was having on his joints. He also referred he had weight loss, polydipsia, polyuria, and the skin lesions were flared and even more painful. Corticoid-induced diabetes were diagnosed and insulin was started. The plan here was to switch to adalimumab because that was the medication we had available at our service. But quantiferon returned positive. He started chemoprophylaxis for TB for 6 weeks, but he developed psoriasis flare with very widespread lesions in almost all of his body. These lesions were very pruritic and also painful. We started narrowband UVB, and the patient only had a DLQI of 7. By July of 2024, we were able to start adalimumab, and after 3 months, arthritis pain improved, but he developed new lesions in his face, and the plaques he had in his trunk and his lower limbs were more red, more scaly, and more thicker scales, almost very yellowish. So he also developed nail changes with destruction of the nail plates of most of his finger toes, and paradoxical psoriasis was diagnosed. We stopped adalimumab. We were able to start upadacitinib 15 milligrams a day with mild improvement of the skin, of the itching, and the pain and the arthritis. After 6 weeks, we were able to switch to ixekizumab. This was the patient with upadacitinib. We can see a mild improvement of the skin lesions and in the pain, and he started ixekizumab on January of this year, right in the day of my birthday. And after 10 weeks on ixekizumab, we can see that the skin was almost clear and the pain was much better. But at week 16, ixekizumab was discontinued for 2 months due to lack of availability, and symptoms again got worsened, especially joint pain and skin lesions on his legs. The plaques turned very thick, very hyperkeratotic, almost like varicose psoriasis. And one of the patient quote in one of the latest visits, it was that he could not get off his car. He's a platform driver for over than an hour, and that was really very frustrating for me. So finally, ixekizumab was restarted in July, 2 months ago, achieving pain relief within 3 days, and the picture in the right is how the patient is today. Well, psoriasis symptoms go beyond skin manifestation. This particular case involved axial arthritis, peripheral arthritis, and severe cutaneous manifestations that were very itchy and painful, including a paradoxical switch in psoriasis phenotype. Persistent pain prompted self-medication with corticosteroid, and this led to severe complication in this patient. Pain in psoriasis is not just a symptom, it is a daily burden that affects mobility, self-esteem, and quality of life. Accessing to care and treatment, even with systemic classic treatments and even more with biologics, is still very difficult in many countries, as in mine, and an early diagnosis and a proper treatment of very severe psoriasis is still a challenge in many places. Thank you very much.